Ora si registrerà la conferenza.
Good evening to everybody.
Good evening.
Hello. I want to say hello to all the colleagues connected right now. And in this period, during the coronavirus stays in our house, I just thought to propose to collect some videos for all of you to see some surgeries, to discuss about some clinical case that is my daily practice. Actually, I resumed some videos that I took in the last days to try to test some cameras. Some of them I wired into with the magnifiers, with the glasses, and some of them connected to the Shalitic lamp. First of all, I want to thank Claudio De Giglio, the CEO of Metalgonomica, that invited me for these lectures, and all of you for having invited me. I want to say that the friendship between me and Claudio De Giglio was born actually because of the magnetic mallet, because I'm a proud and an enthusiast utilizer since almost 5-6 years, and so we met thanks to this device. And the reason I'm here is because I'm really in love with this machine, and I use it every day in my daily practice, because I do surgery every morning, and almost every morning I use the magnetic mallet during the extractions procedures, during the crestal sinus lift, during the crown remover, because it's very useful for the crown removing when we have to remove the some prostheses that are cemented with definite cement. And so let's start with the first video. This one. Okay, this video is the same clinical case that you saw during the teaser of this webinar, because it's about a crestal sinus lift and then the immediate implant. But in this video I collect all the pictures to have the final outcome of this clinical case. So let's see the video. We see that we had to remove a hold implant with the communication with the sinus, and we did an immediate implant where this number 15 was replaced with an implant. And this is what I often do. Sometimes I quit the video so we can stop and talk, because sometimes I see that we have okay, nothing, no questions. So most of the time I used to utilize the ultrasonic device, or Trifine, or directly the osteotome to the crestal when we have type 3 or type 4 bone, to move the ring of bone apically into the sinus. And this is the case. We can see why. Okay, so see, this is the case when I went directly with the osteotome into the crest to move the bone apically, and every millimeter I checked with my loops, with my magnifier and the light, where is the bone. Here we can see perfectly the ring the bone that we moved apically into the sinus to do the crestal sinus lift. I don't know if you hear the music, but maybe we don't need it. Okay, this is the images within the close together to each other. And with this technique, we don't use actually any drills. This is the suture. And one important thing, I stop for a while the video. One important thing is that most of the time we can perform one-stage surgery, so we can screw immediately or abutment, or most of the time I do with healing abutment, and this and sometimes some implants have the very tight connection. Sometimes it's conical or conomorphs, so actually we need to screw very well the healing abutment, and that means that we have a good torque, insertion torque, and good primary stability. So this is the 3 months X-ray, and this clinical case is today is almost 4 years follow-up. Next video I prepared is about a technique that I use lately very much. That is for me one of the best way to preserve the bone structure and the peri-implant structures. So I used to do a lot of immediate implants in the past. I used to do a lot of socket preservation with biomaterial or membranes, but lately I'm using this technique that is called partial extraction therapy or socket shield technique, and this is one case. And I did 3 immediate implants in position 13, 14, and 15. The 15 is with the crestal sinus lift, and I used both manual expander and magnetic mallet. So let's see the video. I'm sorry, one second.
خلاص complete. خلاص Mallet Shot.
I don't know why it's not. Okay, wait a second, I'm closing it. Listening to there's something wrong with the software. Okay, wait. Okay, let me see. Hmm. I'm sorry. Okay, this is the second. Here we are. So here we have the clinical case, the 3 hopeless teeth that we have to remove. This is the combine, which I choose to do the socket shield in every single root. I cut the crown and I prepare through the roots with the drilling through technique to have the ideal prosthetic position of the implants. Then I prepare the socket shield, and this is the tips that I use to remove the palatal fragment of the root. And I use the bone expanders and the magnetic mallet in the last one to perform the crestal sinus lift. This is for me the best way to preserve the native structure of the patient. I utilized bone collagen in the gap, no biomaterial, and second intention healing after suturing. This is the post-op X-ray. And after 4 months, this is 11 days after the surgery. This is 22 days after surgery. And this is 4 months. We can see here the CBCT that when we can see bone between the shield and the implant, the healing, and the removal of the healing abutment. These are the impressions, the final abutment, and now the case is here because we took the impression of the metal cast, but actually then the office was closed because of the coronavirus. So actually we are here with the provisional, sculpting the gums to try to have some papillas between the implants. And here the temporaries. The temporaries in place just after the delivery. This is the impression of the metal cast. Okay, now let's find the other video. This video is my first try with the little camera that you can mount on your loops. It hasn't got the stabilizer, so please the video is not very stable because of this. So I'm sorry for some images, but the case is interesting, so I decided to show you. So the case is about wait, I'm going to, this case is about the two implants that we had to insert in position number 16 and number 17, and we have in the both of them sinus lift to perform, especially on the first one. You will see that in the number 16 I tried to do an immediate, but then I had a little perforation that I'll show you. So I did after 3 months re-entering, and I inserted the implant. This is the CBCT of the number 16. Okay, this is the anesthesia, so we can or maybe go faster. Okay. In this webinar, I will show you many type of cameras. This one is the first one that I tried. Here I did the separation of the roots to perform with the magnetic mallet the luxation of the root, of the 3 roots, and after separating them I went with the magnetic mallet to separate the root from the adjacent bone, and then I utilized the forceps to extract them very easily, and especially preserving all the bone around the implant, the roots. Here the image of the residual bone. So what I did, I tried first of all, I inserted the number 617. So I opened the flap. I wanted to see very well where is the crestal bone, and then I used the magnetic mallet directly to the bone. The crestal sinus lift in the number 17 was not so much, about 3-4 millimeters. And every time I use the osteotome, I want to check visually where I am. I always want to see bone apically, always. Then I use collagen and I fracture the cortical of the sino wall. You see now I can check with my eyes where I am, and I want to see or collagen or bone. Then I go back with the osteotome and the magnetic mallet, and I perform the sinus lift. This is in real time. We take about 10-15 minutes. When the bone is soft, it's very easy. Because the magnetic mallet, as we know, is very effective. It's very powerful, but actually the skull of the patient doesn't move. What is moving here is the camera, but actually it's not even the camera, it's the processing of the image with the cell phone. I didn't like that. Okay, then I inserted the implant manually, so we can feel very well the consistency of the bone. Sorry about these images, but it's about the camera. Okay, number 17 is inserted. Cover screw. Usually I don't use cover screw. In 98% of the cases I use the healing abutment. But this was really, really poor quality bone. Here you see the septum is very thin, so I tried to move some bone apically and perform at least a beginning of a crestal sinus lift, but actually was too thin, and I did the perforation, a very small perforation. I will show you in a while. So I decided to put a lot of collagen and close it. Here, now we have a perforation. I will stop the imaging when the perforation is going to be seen. Here we are. This one is the perforation, very small, but actually I stopped and I decided to go ahead without performing any implant in this case. So I put collagen. Okay, the membrane was there. You see? A lot of collagen. I can go faster now because we don't need to see everything. Oh, collagen, 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 collagen. A lot of collagen. And after that, I tried to achieve a primary stability, not really a primary closure of the flap. So I did some cutting the periosteum to have more tissues to close the flap. Because of course I was afraid about the perforation. Not a big deal. So let's go faster because this camera is pretty disturbing. Okay, then collagen again. And we closed everything. Okay, this is the suture. And I tried to achieve the primary closure of the flap. I didn't perfectly in the medial aspect, but you'll see that the healing was very nice. Okay, let's go faster. Please forgive me. This one is the worst video because it's the try of a camera, and I think the camera is better than this, but maybe was the CPU of my cell phone that was collecting data. That this is the final images that I had from this camera. Actually, my head was not moving. So, okay, this is the suture. In a mesial aspect, we had primary intention healing, secondary intention healing, and this is the healing after 3 months. Okay, the perforation didn't have any issues, and this is the 4 millimeter, 3 millimeter and a half, no, 4 millimeter 0.2 in this part, and this was lower, and here a little bit higher. So we went through the insertion of the implant, in this case also with the magnetic mallet. This is the density of the bone of the software in the aspect buccal, mesial, and distal. The CBCT. And finally, we could insert the implant after, I think, 4 months. I performed mucotomy because I had a lot of keratinized tissues, so I used a countersink to remove the bone around the implant, and I inserted the healing abutment on the number 17. Then I opened the flap, and the performer sinus lift with the magnetic mallet and collagen. Here is the image that you can see the apical aspect of the osteotomy, and the implant, and the closure, and the suture. This is the after suture removal. On the in here we can see in the 26 and 27 we had 2 implants with the 2-3 years of follow-up. This is the second stage after 3 months. Same flap. Healing abutment, roll flap. The healing of the tissues at the point of the impressions. Transfer copies. Impressions. Final abutments. Final abutment torqued into the implants. Temporaries. And that's it. We have a final abutment and temporaries because even this case is still finishing. Next video is another try with another camera that I used. This camera as a stabilizer actually, It's the same of the other one, but with the stabilizer. And I performed a flapless on the tooth number 27. I mounted the camera on the loops, but maybe I will do some tries. Better tries with the helmet. But let's see the case. Of course, this 27 is in a treatment plan that is more complex and is about all the upper jaw. This is the CBCT of the face. The anesthesia, we go faster. You see that the images are better with this camera because we have a stabilizer. Okay, I choose the dimension of the mucotomy. In this case also I have a lot of keratinized mucosa, so gingiva, so I removed the tissues, a lot of mucosa, and this is the first osteotome I used, just to reach the length close to the sinus floor. Second osteotome. You see the noise, and you see that the skull of the patient is not moving. This is the 300F. And the last one is this 330F that I use when I want to insert 4.5 implant. You see 330F. With this osteotome, I remove the bone laterally, apically, and we perform very easy crestal sinus lift. In a flapless surgery, we have to screw the implant, and we have to see very well where the platform of the implant is, because we want to insert the implant crestal or better 0.51 millimeter subcrestal. So we check and we decide to go further. Very good primary stability, so we can insert the healing abutment immediately. This is right after the surgery, May 2019. Seven days post-op, and at 3 months we have the CBCT and the healing with the new bone apically and around the implant. This is the healing of the tissues, compression, and final abutment. Shoulderless, like I love it. And this is the final abutment, the way of delivery of the provisional, because now the treatment plan is going further. I have another video to show you. And this video is about immediate loading of 13, 14, and 15 with the socket shield in the number 13. And when we reached the healing of these 3 implants, we went distally to perform 2 implants in position 16 and 17. Okay. I don't know where. Okay, here's the video. Okay, we had to remove this broken implant, remove these 2 roots, but this one I keep the socket to maintain the buccal plate of the canine. Okay, and the patient's already lost this implant. This is a very bad situation. You see the sinus lift is this one. So these are the clinical images. The WhatsApp of the temporaries. The CBCT, very thin crest in position 14 and 15 where we remove the implant. And this is the canine. Okay, for example, here we remove the implant in this way. We use the mallet, inserting the tips in this area or in this area, and with the strokes of the mallet we moved the implant, and we can reach the losing of the attachment of the implant to the bone, and then with the forceps I screwed very easily the lost implant. You see the very thin crest, the implant 14 and 15. Then we put some biomaterial vestibularly, and we inserted the temporary abutment to do the immediate loading here and here. Especially here, we inserted the biomaterial to avoid the resorption of the buccal plate. And here is the shield that we left buccally to the canine. Here are the X-rays after the surgery. After the surgery, the temporaries, in the day of the suture removal. A lot of chlorhexidine was used by the patient. And 5 months later, this is the CBCT of the 3 implants. We see everywhere on the bone, especially on the canine. And this is the CBCT of the number 16 and the number 17. So number 17 is not very difficult, except for the quality of the bone. So we can use the bone expander and the magnetic mallet alternatively, but on the 16 we can use the magnetic mallet directly to the crest to move the bone apically. Here in these images is the healing of the socket shields, very natural healing, but we have some bubbles here of fluids. So after the spray, we can see that I left a part of the shield exposure in this case. So in the video, we'll see first the exposure of the shield removal. This one is another camera. It's another camera that I mounted on the chair light. So I removed the shield exposure and inserted back the temporary abutment. So I did the incision distally. Okay, let's go faster. We opened the flap. We cleaned all the area where we did the extraction. Okay, we remove some tissues where the patient lost a teeth. And now we see very well the crest. So this is the mallet, how it works. We went directly to the crest with the mallet. You see? You can hear the noise here. This is how the mallet works. It moves the bone laterally and apically like an orthotome does, but in a very, very effective way. The patient doesn't move the skull, and the orthotome go very fast, but with a lot of control in the bone. About 1 millimeter every time. Okay, this is the Osteotome 300F, and this one is the 330F. So we remove from the osteotomy, remove the circumferential bone apically, and we translate the bone apically to insert the implant. This is the images after the osteotomy and the implant insertion. What we reach with the osteotome techniques is that the bone is an elastic material. So when we remove the bone, actually the bone want to replace this original position. So the stability of the implant is always very, very, very good. In the number 16, we used directly the last ossetone, the 330F, because the bone is very thin. So you reach directly with the last ossetone. And every time, yeah, you see this, the skull of the patient is not moving. After I broke the sinus floor, I used the Versa drill. In this case, I'm not using every time, but in this case, I use the Versa to have the hydrodynamic moving of the Schneider membrane, and to move apically the bone, because actually I'm already into the sinus, so I don't need the mallet anymore. I prefer to fracture the sinus floor with the magnetic mallet instead of the drills. Actually, I don't want to use the drill. Okay, if you have question, wait a second. I'm gonna stop the video, and I need to see the questions. Okay, wait. It is okay to okay, yes, turn on the okay, questions. Okay, if you have question, I'm here. Hi, doctor. Why not to use PRF instead of collagen? Yes, the answer is because I don't have PRF in my office, but I agree with you, is maybe the best. Yeah, good question. Poi, ossetone without burrs directly into the bone? Yes, the answer is yes. Any other questions? Temporary abutment are Teflons? No, is PEEK. PEEK is polycarbonate. Okay, if you don't have other question, I can go ahead with the. Okay, with the. Tell me when you want me to go ahead. Okay, I'm going ahead, and then when you want to ask other questions, okay, cool. 1 second. Okay, so I use the drills only to, but you see with the vibration and the moving of the burrs, actually we move the head of the patient a lot more than we do with magnetic mallet. This is the truth. You see how the patient is moving, because I need pressure with these drills, and actually I'm scared about the heat. But this is the result, and we insert the implant. The implant that I prefer to use in the crestal sinus is an implant that is conical and not cylindrical, and if it's possible with a round tip, but it's not mandatory. You see that we have a good primary stability in the type 3, type 4 bone, and with initial height that is very, very low. It was about 3 millimeters, maybe less. Okay, cover screw is very rare that I use cover screws, but actually the patient didn't wanted to avoid another surgery actually. So this is the suture. I think we'll do a connective tissue graft buccally to the 14 and the 15 because the crest was very thin and we need the tissues, but this is still temporary, so we will do it in the future. The canine is perfect with the socket shield. Okay, a very easy suture, a continuous suture. And this is the OPT post-op. So we'll see in 6 months what is gonna be of 2 implants. Next one. Sorry. Okay. Next one is number 6. This is another video. Okay, this is another video. Is about is a number 16 that we tried to save with the root canal, but actually we had a very a pocket majorly to the number 17, and we had a problem in the buccal aspect of the root. So we decided to remove the tooth, and we did the socket preservation, and we treat the pocket majorly to the number 17 with biomaterial and fibrin glue. So we see here the case in this video. The same patient in 2015 had an implant in tooth number 37. This is the implant in November 2016, and this is June 2019, where we had to manage this situation. We tried to save this tooth with the root canal, but the problem was this root that had a big loss of buccal bone in this area. So I didn't want to do the immediate implant because of this pocket. So I inserted bone until here, and starting periimplantitis in this element 45. There's a question, sorry. The question is, could you please tell when you suggest to use mallet instead? Okay, I already said that the Versa burrs, if I can, I'm not using it. Sometimes I want to use the Versa when I already fractured the sinus floor with the mallet, and I want to have a better control when I have to use biomaterials inside the sinus floor. If not, I'm not using the Versa burrs. I have the kit already with me, but on 10 times I use 8 times magnetic mallet and 2 times the Versa drills, because actually I prefer, I use most of the time magnetic mallet and manual bone expanders, because I don't I want to avoid to use drills. Why don't you use screw retain temporary crowns in socket shield technique? But actually I have nothing against screw retain temporaries. Sometimes I use it, but for me it's easier to prepare in the mouth or outside the mouth the temporary abutment, and then to rebase the crown. But I'm nothing against the screw retain. I'm not afraid about the cement, because I always use shoulderless preparations, so I know where I want to put the limit of my crowns, and I always with magnifier control very carefully if we have cement. Why don't you use PRG or repair augmentation as screw retain crowns? Because I don't have PRG or PRF in my office, and actually I don't have an office because I'm a consultant surgeon, and we were starting a few months ago to all the process to have this in the office. So in the next future I will use PRF, and also as a biomaterial the dentin of the patient, but until now I didn't. Why don't you do solo crowns instead of connecting them? Because what do you mean? In the immediate loading, I always splint them, and even in the final, definitive crowns, the prosthodontic used to, as a final prosthetic, the prosthodontic prefer to splint them. Most of the time I'm not, I'm only the surgeon of these cases. Is a way of thinking, maybe a little bit old, but it is working, because in the office where I am main consulting, they used to have bicon implants, and they used to splint the bicon implants with also natural tooth, with the how do you call root canal. When I have low sinus, I prefer to use the hips with PRF. I think more safe than the cortical sinus lifting. Well, I don't know very well the hips system. I mean, I know, but I never use it. And I started with Summers many years ago. I started with Bruschi and Scipioni with the osteotome techniques. So when Mallet came into the market in 2012, I bought Magnetic Mallet in 2014, and actually my learning curve was with the magnetic mallet, and I have no problem with that, so I'm not gonna try something else. I decided to try the Versa drills, but actually I feel more confident with the magnetic mallet. Okay, you're welcome. So let's go ahead. Okay, this is the element that we have to remove. The number 16 with the densitometry of the CBCT. The root that we separe, and we extract it now. In this case, I'm showing you the root after the removal with magnetic mallet, because lately I have to tell you that I'm using very much. I didn't use it very much in the past, but I'm using very much lately because of because I'm doing a lot of socket shields. So I'm using the magnetic mallet in the extraction maneuvers, and I tell you that it's very fast and is very effective, and we can really preserve the bone structure around the roots, because you luxate the root very easily, and then you can pull it off. So this is the aspect when we remove. This is the here we can see the pocket. We lost 3 millimeter of buckle plate in the medial aspect, but not buckle plate in the distal. So here I use biomaterial fibrin glue and collagen without any suture. It's a kind of sticky bone, but very, very sticky. And here we can see in the number 45 the periimplantitis that is getting worse. And after this is after 9 days. 4 months later, it's very funny because I said to the patient, okay, now 15 minutes, I'm gonna insert you the implant in 16 position, and then if you want, we can do the lower jaw with the periimplantitis. I try to save your implant that is lost, and the patient said, okay, let's go. But you will see in the video, I used the first mallet, then the densa burst, then I used the bone expanders like many times, because the cortical, this kind of bone was very tough, and the cortical was very hard. So I took about half an hour to insert this implant, but lately the patient wanted to go on the lower jaw same. So let's see the video. Okay, I'm designing the flap. I love to use the number 12 blade, but I know it's not really common, but I love it. Okay, I wanna say to you that this is not the last video. I have another one to show you. So it's gonna be 15-20 minutes more. If it's okay, I go until the end. It's okay for you? Here is a trick that I use some cyanacrylate to fix the flap to the tissue of the patient to have better visual. Okay, here is mallet. It's too noisy. Can you mute the microphone? What are you saying, Grafko? Okay, here we can hear the mallet, but the bone is very hard. So I try to use the Versa. Okay, here we can go faster because I use a lot of. Okay, actually. Okay, perfect. Because I wanted to hear the noise of the mallet, but it's okay. I can shut down the music. So I use the Versa drills here. You see how the patient is moving with the Versa because we need to push a lot. With the mallet, actually, the effectiveness is better. You see, the patient is not moving like that with the magnetic mallet. You'll see later. Okay, forward, forward. Very, very hard bone. This is the images when we use the drill. So when I saw that bone, I said, okay, I want to use the manual expanders because I want to countersink the bone. I want to see the blood. So here I use the bone expanders. But when I reach the sinus floor, the bone expander was doing spinning. So I tried again with the Versa. Then again with the magnetic mallet. Again with the bone expanders. And here with the mallet. Last try with the bone expanders. Then again, actually I wanted to show you this case because this is not common. Usually is as I said to the patient, I'm taking 15 minutes to do the crestal sinuses and insert the implant because the magnetic mallet is very, very fast. You see, I'm still pushing against the sinus floor. It's not erosing. So finally, I reached a beginning of the sinus lift with the bone expanders, and finally I did the crestal sinus lift with the implant. I'm going faster because it's already 9-10 minutes. Okay, now I had the perceptions that the crestal sinus lift was done. In this case, using everything, but it's never happened. Maybe it was because the biomaterial with the fibrin glue that I used it was very, very strong. Here the images after the last expanders. So we have blood, and I used just 2 seconds the drill to use the hydrodynamic pressure for the Schneiderian membrane, and then I inserted the implant. And the implant did the last move of the sinus floor, and you will see in the X-rays what happened to the sinus floor. Okay, faster. Manually, I inserted the implant with the manual hand driver because the stability was very high. This is the image. So I inserted the healing abutment. Here I removed the acrylite on the flap, and I did this final suture with a roll flap. Last suture. Final image of the roll flap, healing abutment, and these all the tools that we use in the really peculiar case, because it's not always like that. I wanted to show you a real difficult case. But we didn't finish. The patient accepted to go in the lower jaw. So I removed with the magnetic mallet, with the crown remover, the final crowns, and the one final abutment went away. So I put the healing abutment of bicon. And this is the image after cleaning of the periimplantitis. And I used I took connective from the tuberosity, and I sutured the buccal aspect of the flap, biomaterial with antibiotics, and I closed the flap. Of course, this was a lost implant, but I tried. And here we can see here you can see the sinus floor that was very hard, but we put it just up to the implant, and this is the biomaterial that I used. And then we closed the office for the coronavirus. So this is the June, November, and the March 2020, with all the situation compared. And here we can see better the crestal sinus. And the distal pocket was resolved. Okay, last video. Oh, no. I don't know what happened every time. Okay, last video. Why? This video was done with a microscope, and is about tooth number 26, 27. I removed an implant, an old implant with no buccal bone. Il bello della diretta. Yes. And here, when I removed the implant, I performed a crestal sinus lift without inserting any implant, because was a really bad situation. You see 1 millimeter of bone. So I put a lot of collagen, no biomaterial. Of course, if I add the PRF, no, I did put biomaterial here. But of course, if I had the PGRF, I would insert the PGRF. And this is right after the surgery. This is after 3 months. And actually, we had two situations. The 26, number 26, that is an impossible situation, or a very hard situation, and 27, that is a pretty normal situation for a crestal sinus lift, about 4 or 5 millimeters. This is the video. This is the initial situation that I had after the extractions. Here we have the crest. So we went initially with the drill because I wanted to be sure to insert because of the position, I wanted to be sure to insert the osteotome in the right position, just for 1 millimeter, just to remove the cortical aspect of the crest and the biomaterial that I inserted crestally. I didn't want to stress, to compress too much the biomaterial, because it's not native bone. Here on the 27th, and I used manual expanders. I was thinking was a really easy implant to insert. Okay, so I inserted this is a microscope video. I'm not using a microscope during the surgery, but at the time I used, and I tried to do some video. And so actually using only the expander, I inserted the implant in the position number 27. Okay, let's go faster because we don't need to see how to screw an implant. Okay, perfect. I'm looking at the chat, so if you have question, feel free to do it, because this is the last video. So while we see the microscope, we can answer to the questions. Next, we'll see how the magnetic mallet go into the impossible implant on the tooth number 26. That is where you see the initial burr that I used. Okay, now we go with the osteotome of the magnetic mallet. And here I used directly the last osteotome. This is the initial drill. You see already bone, but you can see the membrane. No, this is not the last osteotome, is the 300. After that, I will use the 330 and move more bone apically. This one was to reach the sinus floor and to fracture, and to do at initial crestal sinus lift. As you can see, I always checked with my eyes where I am. And now we go with the larger diameter. You see, you can see here very well where is the native bone. We already are in the sinus. So what we do, we use the large diameter and we move the round bone apically, because we already fractured the membrane. This is typical summer technique. I didn't invent nothing, and the magnetic mallet make this technique very easy. Now we are facing the membrane, and with the microscope we can see very well. Okay, but still we have bone apically, you see? Two millimeters of bone, and we inserted a 7 millimeters implant, 6.5, ultra short implant. Now I'm not using ultra short implants anymore. I always insert 8 millimeters. But this was one of the first crestal sinus lift I did with the magnetic mallet. Okay, the two implants inserted, and this is right after the surgery. I put biomaterial here. Here I inserted biomaterial because the crest was very thin. This is the sinus. Okay, we can see. But what happened? After 6 months, I did the second surgery, and of the two implants, I had the failure of the 27, and the impossible implant on the 26 survived. So now I inserted an implant on the on the 27 distally. The same patient had the 3 implants in 16, 17, and 15 with the crestal sinus lift, as you can see, with magnetic mallet. This is the best situation when we have 4 or 5 millimeters in 5 minutes we do crestal sinus lift. The fastest way to do sinus lift. Okay, this is the final crowns, and we go back to the 26 and 27 area. I lost the implant on the 27, so I put it another one distally that nowadays has a final abutment, and this is right after the surgery, and now this adding abutment, and now we have. Why did you quit using short implants? I'm still using short implants, but 8 millimeters. I'm not using the 6.5 anymore. So we finish with the video, and I want to show you three more slides. Allora, one slide I want to show you is this one, where we can reach my Facebook account, my Instagram account, and especially YouTube account, where you can find all these videos separated, and please subscribe to the channel. And thank you, Dr. Rusevic. Thank you very much. It was nice to having you. And I want to show you also this slide that is about a offer that your distributor gives to you. If you purchase a magnetic mallet, you will have a one-day hands-off training course that will do it in Zagreb, Croatia very soon. We hope so because of the coronavirus, but we will do an one day hands-on in Zagreb, Croatia. So this is the offer that you can have. And finally, I want to tell you that next week you'll have another webinar with a friend of mine about also distraction step by step, the protocol, and so please be there to see this webinar. So I hope you enjoyed the lecture, and I want to thank you for being here with me.